Hello, everyone. Our topic today is a continuation to our previous presentation about low back pain. Today, we'll be discussing the anterior compartment, which is more sophisticated than the posterior compartment. And when I'm saying anterior compartment, as far as the spine goes, I do mean the vertebral bodies and the disc. So we'll start with anatomy here and the nerve supply of the disc. As you see, the disc is basically supplied by a nerve called sinovertebral nerve, right? Which actually supply the posterior aspect of the disc, while the lateral aspect is supplied by the gray ramus communicans. All right. Now, as far as the vertebral body, it's supplied by a nerve called the basivertebral nerve. And recently, we've been able to block this nerve and in fact, do radio frequency. Okay. We'll talk about the procedure later on during our presentation here. But this basivertebral nerve is also a branch of the sinovertebral. As we discussed before, we have common causes of low back pain, including herniated disc, degenerative disc disease, annular fissure, tear. Then the stuff that we talked about as far as, posterior compartment, the zygophysia, the joint arthropathy, or what we call facet arthropathy, central canal stenosis or foraminal canal stenosis. Now, stating this, we have also rare but important causes of low back pain. These are the ones we say these are the red flags of the low back pain. These are the ones that if you hear about them, you need to send the patient immediately to a doctor or to the emergency, such as epidural abscess, epidural hematoma. If you're suspecting this, you need to really work very fast on the patient. Discitis, osteomyelitis, metastatic cancer, or even primary cancer. And then referred low back pain, such as abdominal aortic aneurysm or pancreatitis or renal colic. I picked up one time abdominal aortic aneurysm. I had an elderly patient in his 80s that came to me with low back pain, and it was pretty vague low back pain. This is not the type of low back pain I've seen before. Patient is just, doesn't have anything tender, nothing really in the exam whatsoever that can point out to the diagnosis. So I ordered an abdominal ultrasound, and guess what? It was an abdominal aortic aneurysm. Facts. Routine clinical evaluations are unable to provide a specific diagnosis 85% of the cases. Imaging confirms it, but doesn't diagnose it, and nor it indicates where the pain is coming from. Imaging miss early disruptions, early facet degeneration, spondylosis, and arachnoiditis. MRI studies reveal an incidence of lumbosacral spine abnormalities as high as 50% in asymptomatic patients. Task force recommended against diagnostic testing, including imaging studies for low back pain within the first 4 to 6 weeks. These facts are so important in your clinical practice, guys. So don't jump into conclusions because you find, for example, a sign that is saying that this is, for example, facet disease. You have to look at the whole picture, clinical exam with the imaging, and also this could be helped by doing injections because the low back pain has multiple sources and makes it very difficult to diagnose. Despite it looks pretty easy from the outside, but it's really deep and complicated. MRI can be used to look for two specific findings: modic changes and high intensity zones. Remember these two, guys, modic and high intensity zones. Both of these features are independently correlated with pain. However, they are not exclusive to the symptomatic population. They are not pathognomonic for the segment being the cause of the pain, but are highly specific. Modic changes occur at the end plates and represent current modic type 1 or past modic type 2 inflammatory changes. High intensity zone represents circumferential annular tears with a sensitivity of 45% and specificity of 88%, while the modic changes has a sensitivity of 24% and specificity of 83%. Bottom line, modic changes for end plates, high intensity zone for circumferential annular tears. Modic changes, type 1, type 2, and type 3. High intensity zone, HIZ, pathognomonic for annular tear. How about herniated discs? Well, we have to differentiate between herniated disc and internal disc disruption because this is a very common encounter. With herniated disc, the MRI shows disc herniation and spinal cord compression, while with internal disc disruption, the MRI does not show disc herniation nor cord compression. Usually, this phenomenon causes axial pain. It doesn't cause radicular pain. This one, if you herniate, you will develop, radicular pain. Guys, this is extremely important in the understanding of low back pain issues here. For example, this is a bulge here. Types of disc herniation. It starts from a bulge or protrusion, going up to extrusion, going up to sequestered or free fragment. If it's just a bulge, guys, probably the patient will be complaining about low back pain. Now, if it starts to get out a little bit, maybe you'll start to have some leg pain or what we call radicular pain. Then, if it's extruded, you will have low back and leg pain. If it's sequestered, you will have a free fragment outside, and this can cause mostly mostly radicular or leg pain. Discography. Discography is an important aspect of imaging besides MRI. However, we do it not routinely. We do it only in certain circumstances. Why? Because it has a high false positive, results. And then you have to have at least one disc negative. Also, other factors should be considered, such as pain concordance, disc morphology, pain elicitation, and so forth. There is also some controversy about discography accelerating the disc degeneration. So, when do we do the discography? Okay, or what we call provocative discography. Well, uh, we do it in suspected discogenic pain, or what we call internal disc disruption. All right, should not be used as a routine of evaluation for patients with chronic non-specific back pain. Also, it's used in preoperatively before doing lumbar fusion. Okay, to pick up the vertebrae or the discs that are affected to be included in the fusion process. So these are the main two, reasons we do provocative discography. The disc with provocative discography, the disc is pressurized until you reach 90 psi. PSI is American unit for pound per square inch. Until the pain is elicited. If the pain is provoked less than 15 psi, the disc is considered chemically sensitive. This basically indicates that the disc is highly sensitive and doesn't require increased pressure to respond. If pain is provoked between 15 and 50 psi, the disc is mechanically sensitive. If the pain is provoked between 51 and 90, you have to investigate other sources of pain. If no pain is provoked by 90 psi, the disc is considered negative. So if you think about it, we're interested in the zone of 15 to 50 psi because this is the one that will let us know this is a mechanically sensitive or not. It actually might pick up the mechanical causes of low back pain. They love these questions in the boards, by the way. So you better be prepared. I don't do these discographies myself. However, it's part of your curriculum. You have to understand when to use them, because in certain circumstances you might need to have someone do them for you, or if you're good at them, you can go ahead and do them. But remember, this is a procedure that can be complicated with infection, discitis, can give you false positive results. So kind of, be cautious about it. Should not be a routine testing. It should be only in selected cases. We have a classification by, post-discography CT. If you're doing a CT scan to pick up the results, it's called the Dallas discogram, and it's from grade 1 to grade 5. Okay. We'll jump into another important topic, which is scoliosis. Scoliosis, the curve is S or C shaped over 3 dimensions. In some, the degree of the curve is stable, while in others, it increases over time. Mild scoliosis does not typically cause problems, but more severe cases can affect breathing and movement. Pain is usually present in adults and can worsen with age. Scoliosis occurs in about 3% of the population. Uh, Most commonly, it develops between the ages of 10 and 20. Females typically are more severely affected than males, with a ratio of 4 to 1, and the term comes from the ancient Greek scoliosis, which means a bending. Um, to pick up scoliosis can be done clinically and through measurement of an angle called the Cobb angle. All right. And basically, the Cobb angle is you measure, the upper border of the upper part of the scoliosis with the lower border of the lower part of the scoliotic part here. And then you actually drop a perpendicular, and this angle is called the Cobb angle. According to the Cobb angle, the management will be either just physiotherapy or a brace, or if it's a larger Cobb angle, above 45 degrees, you need to have surgical intervention, which is a major surgery, by the way, scoliosis repair. So either physiotherapy, if it's less than 15, from 15 to 45, you might need a brace. And then above 45, you might need surgical intervention. So this Cobb angle evaluation is very important in this situation. Okay, another disease called DISH, diffuse idiopathic skeletal hyperostosis, all right, or Forestier disease. It's a common condition characterized by bone proliferation at the sites of the tendinous and ligamentous insertion. Most commonly affects the elderly patients, 6 or 7 decades, and it's estimated in the frequency of 5 to 15%. It doesn't cause a lot of issues, clinically speaking, but it's a very important radiologic finding. You have to be aware of it because you can confuse it with something else. Okay, so this is how it looks like. Diffuse idiopathic skeletal hyperostosis, DISH. So it can confuse you with ankylosing spondylitis, at least from a radiological point of view. So points are favoring DISH are no backache, no morning stiffness, low ESR and CRP, because this is not an inflammatory process like ankylosing spondylitis, which is a rheumatologic disease and has these rheumatologic markers are basically high. Typical flowing wax appearance of osteophytes. All right, so this is the radiologic appearance, flowing wax appearance. No sacroiliitis. Intervertebral discs are relatively preserved. Points favoring ankylosing spondylitis is basically positivity of the HLA B27. Another condition is basically spondylolisthesis, which mainly means that one vertebrae is slipped over the other. And there are grading for the spondylolisthesis from no spondylolisthesis whatsoever, and then grade 1, which is basically 25% slip, up to grade 5, where the spine is completely off. Basically, grade 1 and 2, you can manage conservative with some injections, prolotherapy, analgesics, maybe some Sometimes we do epidural steroids if you have radicular manifestations, but usually with grade 3 and 4, and higher, of course, you will need surgical intervention. Spondylolisthesis. In this picture, you have what we call Paras defect, Paras interarticularis defect. And when you have this defect, there's a weakness in the vertebral body, and one vertebral body basically slips over the other. These are different types of, spondylolisthesis. The most famous one is the dysplastic, which is basically a congenital defect in the neural arch, what we just talked about, pars interarticularis defect. Then we have the degenerative form, which is degeneration of the facet joint complex, or could be traumatic, all right, with a traumatic fracture of the posterior column, but not the pars. Pathologic could be an infection, neoplasm, endocrine disorder, post-surgical, for example, post-surgical laminic lumbar instability. From a historical point of view, these are the two doctors that uh, discovered the role of the disc in low back pain. And as you see, this article is from 1934. Before this era, the concept was the cause of low back pain is basically the sacroiliac joint. Okay? Nowadays, we know that sacroiliac also plays a role, but it's 10 to 38% of cases only are related to sacroiliac joint. We have other causes of low back pain, which added to the complexity of the problem. All right. So we have discogenic pain, we have, facet pain, we have myofascial pain. So you need to sort out, the cause so you can treat it. These guys, name is Mixter, Dr. Mixter and Barr. Mixter and Barr. Neurological findings for herniated discs. Basically, it could be, as we said, low back pain, and it could be, or what we call axial pain, and could be radicular pain related to these nerve roots, the L4 or L5 or S1. So you need to know how to differentiate between these three nerve roots. Okay. So for example, with S1, you have a weakness in the plantar flexion. With L5 radiculopathy, you have weakness in the dorsiflexion. With L4 radiculopathy, you have a problem with extending the knee. Okay. So here you do the toe walk. Here you do the heel walk. Here is basically you bend your knee and raise it up. And then the reflexes here, it could be lost in L4 radiculopathy, the knee jerk. With S1, you can lose the ankle jerk. While L5, there is no, reflex, involved here. Again, this is basically, how the disc can affect your nerve root. So I want to mention, and I want to compare it with the cervical spine here. Both discs affect same nerve root and cervical spine, different from the lumbar spine. Okay, so a 6-7, disc will affect the C7 nerve root, whether it's a central disc or foraminal disc. But the situation is different in the lumbar area because, for example, if you have an L4, L5 disc, all right, uh, you can affect either the L4 or the L5 nerve root, all right? So the lateral disc will affect the L4, while the central disc or paracentral disc will affect the L5. This is a very important distinction between lumbar spine and cervical spine. And we're going to have a separate talk about neck pain. So how we deal with this, type of low back pain, we'll go back to our algorithm. First, we'll start with conservative management. Then we do spinal injections. And I put to you the list of spinal injections for low back pain, okay? Whether it's a posterior compartment or anterior compartment. The spinal injection is extremely important in evaluation of low back pain. It's not just therapeutic, it's diagnostic as well. So we have false positive and we have false negative. So false positive, using a high volume of injectate can spread to adjacent structures. A placebo response is seen up to 30% of the patients. Using anxiolytic agents can give you false positive results, or systemic analgesic administration, while false negative is due to incorrect needle placement or inadequate local anesthetic volume or concentration, or it could be even unrelieved patient anxiety or overly traumatic and painful technique. So this leads us to the value of these spinal injections. As I said, they're diagnostic and they are therapeutic in the same time. All right? So don't forget that. Let's say you have a facet disease and you inject the facet joint, the pain goes away. Well, I know now that I'm having a problem with facet disease. While, for example, as far as and this will also help with the pain. I mean, so it has its therapeutic value. So spinal injection became, a part of this, algorithm that we use to treat low back pain. So again, we're getting into the lumbar spine algorithm here. We said step 1, the conservative measures, step 2, spinal injections, and step 3, neurosurgical interventions. And to start this understanding of the algorithm, you start with conservative treatment, all right? Whether you have back pain with or without radiculopathy. And then you start to think about back pain algorithm versus radiculopathy algorithm. Is the pain in the lower back or is it in the leg? All right. Remember, radiculopathy is only 15% of low back pain patients will suffer radiculopathy. So the common thing is, the more common is the low back pain. Now, 85% is low back pain, 15% is radiculopathy, and you can have also mixed pictures. Back pain with lower extremity pain. Now, the end road of this back pain or axial pain algorithm is using a pump intrathecal narcotics if everything fails. While with the radiculopathy algorithm, the end result is doing what we call dorsal column stimulator. And then here, the third step in the algorithm is basically the neurosurgical interventions. Now, sometimes you do the neurosurgical interventions or step three before step two in certain circumstances. Okay, so let's start with the axial or low back pain algorithm. So this could be related to vertebrogenic pain, could be related to discogenic pain. These are the basically the anterior compartment elements, and it could be related to sacroiliac or facet arthropathy. And these are the posterior compartment elements. So what are we doing with vertebrogenic pain? We can do vertebroplasty, which is basically injecting semen, or we can do the BVN radio frequency, okay, for type 1 or type 2 MODIC, okay? And the last procedure is the Gray-Ramus communicans radio frequency if everything fails. As far as discogenic pain, we have to start with a discography. And then we can do what we call orthobiologics, okay? Stuff like stem cell, PRP, and others. And also, we have a pretty decent procedure called biaculoplasty right now that we do for discogenic pain. Now, um, there are other procedures available, but I mean, we don't have much evidence about these procedures. So, for the time being, things might change, of course, down the road. But for the time being, these are the procedures you need to know about. Now, as far as the sacroiliac, you can do a regular diagnostic block. You can add some orthobiologics. You can do RF for the lateral branches of S1 to S3 and the dorsal ramus of L5. And eventually you can do what we call SI fusion. Facet arthropathy, diagnostic therapeutic block, orthobiologics, again, stuff like PRP, and radio frequency. Lumbar radiculopathy algorithm. You can start with epidural steroid. The reason we do epidural steroid injections is these patients with herniated discs, they release a material called phospholipase A2, which attacks the lipid membrane and releases arachidonic acid. And this arachidonic acid creates a state of inflammation around the disc here. All right. So epidural steroid injection should be the first choice here in the lumbar radiculopathy algorithm. Could be done through the caudal epidural, could be interlaminar or transforaminal. Now, we have three conditions. We have disc herniation, we have spinal stenosis, we have failed back surgery syndrome. As far as failed back surgery syndrome, you can proceed, with lysis of adhesions and epiduroscopy if needed. With spinal stenosis, we have two famous procedures, one of them called the mild and the other one called the interspinal spacer. These are done by interventional pain physicians. While with disc herniation, you can repeat the epidural or do a dorsal root ganglion, pulsed radio frequency. Interlaminar epidural, steroid injection. This is just another nice picture to show you a myelogram if you inject intrathecally how it looks like. Caudal epidural steroid injections. Um, and I wanted to explain to you an important thing here: the distance between the sacral hiatus and S2. Because if you go above S2, you will get into the intrathecal sac. So this distance is somewhere between 7 to 40 millimeter. Okay, so be careful when go up with your needle, not to pass this S2 boundary. Otherwise, you will end into the intrathecal sac. Transforaminal epidural. Well, you can, go through the what we call the safe triangle, or you can go through with the transforaminal what we call Cambian triangle. The safe triangle is above the nerve root, while the Cambian triangle is below the nerve root. It depends on your comfort level. Whatever is more comfortable to you, go ahead and proceed with. Epidural lysis of adhesion. This technique was developed by Gabor Rex, a very renowned, pain physician. And basically, it's mainly indicated for patients with, failed back surgery syndrome. And the reason we do this procedure is to inject certain material called hyaluronidase enzyme to eat up this, scar tissue, and then follow this with, the contrast, local anesthetic, and steroids. Gabor Rex. Epidural lysis of adhesions. We use a specific needle called, Rex needle and catheter. It's a kit that you buy, because to do your maneuvers, you need a special catheter that doesn't get broken inside the epidural space. Our regular epidural catheter will not be adequate because there are a lot of scar tissue there from the failed back surgery. Um, this is the Rex catheter. Look at the, how it looks like. So if you pull it back from the needle, it will not be sheared off. And this is the needle they use. It's called the Coude needle. So Gabor Rex used the specific needle called the Coude needle. As you see, the bent is kind of not too big like, the regular epidural needles that might, if you use it, might shear off the catheter. Okay, in certain circumstances, this procedure is not adequate, and you have to do a procedure called epiduroscopy. And with epiduroscopy, I'm able to localize the area of the scar tissue and target it directly with this enzyme, hyaluronidase enzyme that eats up the scar tissue. And then you inject the contrast and your local anesthetics and steroids. Also, you can use the hypertonic saline used with Gabor Rex here to reduce the edema in the territory that you're injecting. Disc biaculoplasty. This is a procedure that applies heat to the annulus of the disc. And this procedure is gaining momentum here, as far as the interventional procedures. You need to know about it. Even if you're not going to do it, at least know about it. With this procedure, we use the water-cooled radiofrequency ablation technique, and we do it on both sides here. So we put two needles, and then we'll start burning the nerve receptors inside the disc here. This is what we call biaculoplasty or cooled radiofrequency. All right, we'll jump into the vertebral body, or we have one procedure called the vertebral augmentation. In this procedure, we inject cement in the compression fracture, and it's indicated in a variety of, pathologic conditions such as osteoporosis, malignant destruction of the vertebrae, aggressive hemangioma, or painful vertebral fracture associated with osteonecrosis. There are two procedures that look very similar to each other, vertebroplasty and kyphoplasty. So with kyphoplasty, you stick a needle that has, and then after you put it, you stick a catheter that has a balloon that will inflate, and then it will give you a certain vacuum that you will inject the cement in. The kyphoplasty in general, okay, can help out with correcting, the curve that occurs from, basically the vertebral compression fracture. So it helps with the height, okay. Um, uh, and also it creates a vacuum for the cement that might help, cement doesn't leak to the surrounding areas. These are basically, the two differences between vertebroplasty and kyphoplasty. Of course, the vertebroplasty is cheaper than, the kyphoplasty. Now, if you fail everything, you can try for vertebrogenic pain. You can try the percutaneous gray ramus communicans, which is located here, next to the vertebral body. This is an old procedure that we're not doing that frequently because we have better procedures now, like vertebroplasty, for example, or kyphoplasty. We have also another procedure called the basivertebral nerve radiofrequency. So we can block the nerve that's going to the vertebral body, okay? And again, this is indicated for vertebrogenic pain. Now, this is a relatively new concept of pain here. Basically, what we call vertebrogenic pain. So not every pain that you have from the anterior compartment is related to the disc, guys. It could be related to the vertebral body. So, we were able to detect this BVN, and we ablate it by radio frequency. So this is how the procedure is called intercept. The procedure itself, you go with a needle inside the vertebral body, and then you introduce your this catheter here that will basically burn the nerve in the middle of the vertebral body. Okay, a very fascinating procedure. So again, it's utilized in patients with chronic axial lower back pain greater than 6 months duration, which is refractory to non-operative treatment for at least 6 months. So this is not something you jump on. This is when everything fails, basically. But the most important criterion here is you have modic changes, type 1 or type 2, in at least one vertebral end plate. Or it could be more than one level from L3 to S1 region. Intercept basivertebral nerve radiofrequency. All right, we'll talk about dorsal column stimulation. This is part of, the algorithm for radicular pain. To understand the spinal cord stimulation, you have to understand the spinal cord stimulation waveform technology. So we have 5 elements here that you need to know about: current versus voltage, tonic stimulation, high frequency stimulation, burst stimulation, high density stimulation. So before you start placing a spinal cord stimulator, you have to talk to the rep and understand exactly the kind of stimulation this dorsal column is providing. Is it current versus voltage? Is it tonic? Is it high frequency? Is it burst? Is it high density? This is very important in your judgment, which one will be the best for your patient. Now, spinal cord stimulators or dorsal column stimulators are basically based on what we call gate theory. We're stimulating large fibers. We call them the A beta fibers. Will block the pain through the small fibers or the C fibers. They're carrying basically what we call the slow pain. Okay. And this was basically the work of Patrick Wall and Ronald Melzack. And these guys, they won the Nobel Prize in 1965 for their, discovery here. Again, to understand the spinal cord stimulation wave technology, you need to know, the frequency, the amplitude, and the pulse width of, your basically your gadget here that you're placing in the patient. Because according to this, you will be able to know whether this is is it a current versus voltage? Is it tonic stimulation? Is it, you know, uh, high frequency stimulation? Is it burst stimulation? Or is it a high density stimulation? And you can see here the pulse duration, the amplitude, and the frequency. Okay, this is in a nutshell what you need to know about spinal cord stimulation technology. Now, what is the value of doing these things, the high frequency and the burst stimulation and all of that? Well, the problem is when we started doing this uh, spinal cord stimulation, and this was basically the work of Dr. Norman Shealy, who's a neurosurgeon that invented these techniques here for spinal cord stimulation. At the beginning, we used the tonic stimulation, and it caused a lot of paresthesias. So they came out with these new techniques, such as the high frequency burst stimulation to basically do the stimulation without causing paresthesias. So this is again what we just been talking about. This is the current versus voltage controlled stimulation here. Tonic basically gives you a pulse wave, 200 microseconds with bursts, pulse width 200 microseconds and frequency of 40 hertz. Burst stimulation gives you a 1000 microsecond pulse width and a pulse radio frequency of 40 hertz. The high frequency give you somewhere between 500 to 10,000 hertz. Okay, so this is a comparison between the 3 types of stimulation. As I said, the one where the tonic causes paresthesias. That's why they came up with the new ones that doesn't cause paresthesias. Because a lot of patients they abandon dorsal column stimulation because of the paresthesia. It kind of actually makes them, not able to tolerate, uh, despite, you know, uh, despite the pain relief they might be getting, but the paresthesia could be even worse than the actual pain itself. So again, a comparison between the burst and the tonic. They work on different receptors. The tonic works on the GABA receptors, GABA B. While the burst spinal cord stimulations, they are non-GABA B, uh, you know, um, dependent mechanisms. This has a clinical value that, with the tonic, you can boost it with GABA B agonists like baclofen, for example. But while the burst, it will not make any difference. Recently, we have been even more clever in doing the dorsal column stimulation, at the level of the dorsal root ganglion. And this is the state of art dorsal column stimulation right now. Is sticking the catheter here at the level of the dorsal root ganglion. What we call it dorsal, root ganglion stimulation. So what is the benefit of dorsal root ganglion stimulation? Number one, it's directed targeting. I mean, this has an accuracy of 94.5%. You need much lower energy than a regular dorsal column stimulator. So the dorsal column stimulator will stay with you, the battery will stay with you much longer time. Only 10% of the energy required from conventional spinal cord stimulator is needed with the DRG stimulation. A low risk of lead migration. All right, so this is a common problem with dorsal column stimulators. All right, it has only less than 1% migration rate, while traditional spinal cord stimulation, is around 14%. Minimal effects on body position because of the location of the DRG. The patient can bend his back freely without a fear of lead migration. So it has a lot of advantages, but of course, it needs more skills than just doing a dorsal column stimulator. DRG stimulation, again, you need to put it where in the around the dorsal root ganglion. Um, Now you can do also DRG with pulsed radio frequency. I just wanted to be clear about it. If you're not placing a spinal cord stimulator, you can do pulsed radio frequency for the DRG. And in fact, it will not cause any damage because, the pulse radio frequency temperatures are less than 42 degrees. So it doesn't cause any permanent damage. And that's why we use it when we do the DRG, radio frequency. Do not use conventional in these situations. This is one of the main indications of pulse radio frequency. Okay, we'll jump in another rather important topic, which is spinal stenosis. So, with spinal stenosis, these patients develop what we call neurogenic claudication, which improves when they bend forward. We call this the shopping cart sign. These guys, they do well when they're sitting, but when they walk, they start to develop neurogenic claudication. So the normal lumbar central canal has basically a mid-sagittal diameter of greater than 13 millimeter with an area of 1.45 centimeter square. Relative stenosis is said to be there when this anteroposterior diameter is between 10 to 13 millimeter. Now, absolute stenosis uh, occurs when the measurement is less than 10 millimeter. Surgery appears to lead to better outcomes if the symptoms continue 3-6 months of conservative treatment. And the main surgery for this condition is basically laminectomy. Okay. Another procedure, that can be used is basically either putting an interspinous distraction device like superion, or doing what we call mild procedure. We have three areas of stenosis: central, lateral recess, and foraminal. And these are the causes of spinal canal stenosis: congenital facet hypertrophy, ligamentum flavum hypertrophy, spondylolisthesis, and ankylosing spondylitis. Another picture of a stenotic, spine. Please, look for, the different types of pathologies that can be causing the problem, and that's why you need an MRI. All right, not just to pick up stenosis, it's also to document where the problem is coming from. MRI for stenotic patient here. So there are two procedures for intervention they can do for spinal stenosis. One of them is called the interspinal spacer. Okay, and basically this is an indirect decompression by prevention of extension. Remember, patients with spinal stenosis, they tend to flex forward, so they actually open up the canal. So this is not for L5S1, and it's contraindicated in osteoporosis, and it's contraindicated in a slippage of more than 3 millimeter, in the flexion extension. So you have to do flexion extension X-rays before you proceed with this procedure. The one that most pain physicians, do is called the superion. Okay. There are other techniques, but these are done by neurosurgery more or less. So I haven't really, put them in the slides here, like X-stop and stuff like that. But this is the one that you need to know about as a pain interventionist. Of course, there's a risk of a fracture of this spacer and a migration. It's a small risk, but it's there. It's a very simple, straightforward procedure. Sticking this spacer in between the spinous processes here. And this will prevent the spine from extension, and thus, putting pressure in the central canal here. Another procedure that's very important for the interventionist is called minimally invasive lumbar decompression procedure, or MILD. And this one is a direct decompression by removing part of the ligamentum flavum. And central canal stenosis only due to hypertrophied ligamentum flavum. And this brings us back of the importance of doing an MRI and identifying the cause of spinal stenosis. And the nice thing about it, it can be done from level L1 to L5 level, and it's not contraindicated in osteoporosis like the interspacer that we talked about, nor spondylo. It's not contraindicated and spondylolisthesis less than grade 2. And of course, there's no risk of fracture and migration. And this is basically a mild procedure. You put a needle, you do an epidurogram, and then you start to, remove this ligamentum flavum, and this will actually um, will lead to opening up the space in the central canal. Intrathecal drug delivery systems are also useful in low back pain. It's getting out of favor nowadays in non-cancer patients because of the, you're still using narcotics, you still have, we're trying to avoid basically using opioids in non-cancer pain. But in certain cases, this is the only options that available for you, and you can use one of these pumps, the programmed pumps, basically, made of titanium with a longevity of 10 years. And as you can see, the thickness is 20 millimeter, diameter is 70 millimeter, and usually we stick it in the buttock area or in the front of the abdomen. One of the agents that we use is called ziconotide or pre-alt, which is basically gabapentin intrathecal. I mean, similar to gabapentin, not gabapentin, but it's similar to the mechanism of gabapentin. It blocks these, N-type calcium channels intrathecally. Unfortunately, the ziconotide can cause a lot of neurological, complications, dizziness, ataxia. You have to start with a very small, tiny dose, and you go up on the dose very slowly here, so you don't get these, side effects. The conotide comes out from a marine snail called Conus magus. And by the way, this Conus magus is abundant in the Red Sea. I will end here with the lumbar spine surgeries that we do for, low back pain. You have the laminectomies, okay? You have a fusion, okay? Of course, the surgeon will decide which surgery he will do depending on so many factors. But the bottom line is the surgeon, if he thinks there will be instability after doing the laminectomy, he will proceed with doing a fusion as well to stabilize this lumbar area. Otherwise, there will be no benefit from the surgery itself. So this is basically, in just two words, which the rationale of the choice. If there's a chance of instability after surgery, the surgeon would do the fusion. Otherwise, he will do the laminectomy. Now, I'm gonna talk for a few slides here about malignancy in the spinal and spinal cord compression, what we call malignant spinal cord compression. It occurs when cancer cells are near to the spine and press on the spinal cord. And this can result in swelling and reduction of the blood supply to the spinal canal and nerve roots. The symptoms are caused by increasing pressure on the spinal cord and nerves. Malignant spinal cord compression affects 5 to 10% of patients with advanced cancer. You see it mainly in cancers such as breast, lung, prostate, multiple myeloma. Thoracic spine is affected more, or the commonest site of a malignant spinal cord compression, 70% in the thoracic spine, 20% in the lumbosacral, and 10% in the cervical spine. Diagnosis. It actually can be picked up by accident because the early symptoms is just back pain, and a lot of these patients, they go to their primary doctor and they just order some analgesics and they keep going on and on for some time before we pick up that this is something malignant by doing an MRI, for example. And this is the being subtle in that, it's one of these, problems with the diagnosis. Uh, Motor deficits are more specific, okay, and but it happens a little bit late in the course. Also, sensory deficits, uh, you know, uh, they're even less common than motor symptoms. Autonomic symptoms like bladder or bowel complaints like bowel or bladder incontinence can also occur in the late part of the disease. And this actually, as I said, it creates this diagnostic challenge for malignant spinal cord compression. And I want you to be aware of it. So I really get triggered when a patient, an elderly patient, comes to me in the clinic with the new onset of low back pain without a reason in particular. There's no trauma, no nothing. I really try to jump into getting an MRI or at least a CT to see what's going on here. Because symptoms poorly correlate with the compression level, spinal cord compression can occurs at multiple levels simultaneously. Imaging of the entire spine is recommended. So I had a case one time with the low back pain, and the oncologist did. A patient had a tumor, and this basically the oncologist ordered only lumbar MRI, and this was not enough because it didn't show anything. Later on, we discovered that the problem was the cervical area. So if you're suspecting, metastasis and and malignant spinal cord compression, please order a whole spine MRI. This is a very important clinical tip here. This is basically an MRI for a patient with a malignant spinal cord compression. As you see, the cancer has destroyed the vertebral body here with a spinal cord compression. So what are we doing for these patients? Three things: steroids, radiation therapy, and surgery. And the best is to basically do the three together to get the best results. All right. So the steroids are pretty easy to be done with, dexamethasone. Radiation therapy, you have to send the patient to, a radiation therapy physician here. And you need to also call for neurosurgery to work with it. Key learning points. Chronic low back pain is multifactorial. A thorough history and physical examination coupled with properly selected diagnostic imaging, physical therapy, pharmacological management, and successful intervention or treatment algorithm should be followed. Thank you so much.